So, in my own practice, I used to go to a peripheral hospital where this is exactly what we did. We had a written protocol, step one, step two, step three, right? So, let's say a patient comes with, hospital hyperglycemia management. Step one would be this is the dose of, this is the basal bolus insulin construction. वो written जैसे sliding scale में लिखते थे वैसे ही this is a printed paper. All the patient has to do is just put all the doctors to do just put that printed paper and then it's so see, right now it's at spinal level, but they still have to write the notes. And इसमें this is printed paper, ये डाल दो, right? इसमें लिखा है क्या क्या करना है, insulin, all the so that could be yeah. So my recommendation, I mean, our recommendation could be that let's keep sliding scale. I think these areas. Okay. Yeah. So we already covered how to unlearn sliding scale, and I think what our recommendation should be against sliding scale. But it's an interesting topic. We can also probably write in the consensus as a thing that this is the reason why it's being very popular. It's more of less evidence based and more of convenience based. But I think it can be made convenient if you give written protocols for basal bolus insulin therapy also, which can be easy to implement. Yeah, the problems with it. Yes. Also, also the fact is that sliding scale one of very true. And the other problem is inherently the sliding scale insulin system does not take the patient's nutrition into account. Patient क्या खा रहा है, nil by mouth है, right? So yes, 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 right. Hmm. Okay. Yes. Yeah. Which is very true. Yes. Random sugar and just put, yeah. Very true. Which is very true. And in fact, insulin actually falls in one of the high risk medication category where, I mean, you are actually responsible when you prescribe an insulin, all these responsibilities, you're actually presume that you have taken all this responsibility. So I think if the Dr. Rama, you can just note this down. There's an important point which can be part. We can. So I think, you're right. So before insulin, and this can be part of the before insulin is prescribed, a full set of this data should be available, checklist should be available, yeah, I mean, at least that will also reduce sliding scale use because then the spinal level becomes one more layer of complex. Okay. Fair enough. Let's then move to a very important area. I think one more equally important area and equally important problem is the use of, and I'm sure this is the point which there'll be a lot of discussion. Yeah, let's take that up. Use of non-insulin agents in hospital. Okay. Let me just run through everything and then we can discuss the individual drugs. I'm sure all of us agree that DPP-4 inhibitors are reasonably safe unless there are specific contraindications. Perhaps DPP-4 inhibitors can be used in hospitalized patients. In fact, Dr. Umpierres, there was another study. Sagar, correct me if I'm wrong. There was a study where they looked at sitagliptin in hospital use also, right? So there's a published study on use of sitagliptin in hospital use where they actually showed good outcomes. And so it's a I would say evidence-based data also. So DPP-4 inhibitors, I'm sure most of us would agree, can be given. SGLT2 inhibitors have gone in areas where, initially it was totally said that you do not give it, uh, to an extent where they're saying that probably it also reduces, readmissions for heart failure and other things. So the challenge with SGLT2 is twofold. One, SGLT2 is used as an anti-diabetic But SGLT2 is also used by cardiologists as a heart failure medication or by nephrologists as a renal protective agent. So it may be there in non-diabetics also. It may be. So right now, and this is one area where we need everybody's consensus. And what do you write? There is a warning in SGLT2 inhibitors that you have to stop it 2 to 3 days prior to surgery. Having said that, there is now data to show, a recent data also to show that actually that is not required, and there is in fact studies which have shown that that is probably the risk of the euglycemic ketosis is actually much lower than what people have said. So, as a consensus, as a guideline, we'll of course analyze the new data. But what I want from all of us is to give some of your expert advice on SGLT2. What would you recommend, and would you agree to stopping it 2 to 3 days prior to surgery, or would you say that it's fine to continue if the patient requires to continue? Hmm. Hmm. Yes, correct. Yeah. So there was a recent paper where they looked at yeah. Okay. So of course we'll review the related data on this topic, but point here is sorry. Yeah. So first of all, let's take major surgery, right? Major, supra major surgery, uh, planned, right? Let's say patient has to go major oncological surgery, right? And patient is on an SGLT2 inhibitor. Would you recommend, and it's a planned surgery, would you recommend stopping SGLT2 2 to 3 days prior to surgery? Yes. Okay. Because patient could be potentially vulnerable. You don't know what's going on. Okay. Uh, Correct. Okay. What about a short surgery? For example, let's say patient has to go, let's say cholecystectomy. Yeah, emergency. To anyways, there's nothing much you can do, right? So emergency, the patient comes in emergency. A patient would have already taken SGLT2. Let's say patient has a planned elective uh, non-major surgery. So maybe joint replacement surgery, or maybe surgeries where they don't require nil by prolonged and nil by mouth, or blood loss is minimal, fluid loss is minimal. Uh, would you be comfortable continuing? Yeah? So I think yeah, yeah. So we have to balance that risk also. Yes, right. Correct. Mm. Yeah. Yes. Yes. So all that agreed. Let me put another play the devil's advocate. Put another scenario. All that is true, but patient has heart failure with a rejection fraction of 25-30%. Uh, are you doing harm by discontinuing SGLT2? Because then the question comes, right? Let's say patient has let's say patient has to undergo TKR, right? Patient is an elderly or maybe 70-year-old with a heart failure with 30% EF. Uh, uh, Cardiologist is not keen on stopping the SGLT2, right? Would you then? What would be our take? Okay, but but Yeah, but the argument right now is, in fact, from the cardiology studies now, they want to start SGLT2 as early as possible. There are studies which have shown that putting the patient on SGLT2, of course, there are other reasons, but they say putting the patient on SGLT2 with patient as heart failure hospital admission, you uh, start the SGLT2 before discharge. That is where the things have come to, right? But in this case, we are doing the reverse. We are actually discontinuing an SGLT2 where the patient is already having heart failure. Uh, so it's an area of debate. We can probably, we don't have data either side, right, to say for perioperative situation. But uh, what would be the consensus? Sagar, what's your protocol? Especially heart. Yes. Yes. Right.
Thank you. Considering that we are experts here
Hmm.
with extensive experience and knowing the risks of continuing an SGLT2, the electrolyte and the fluid imbalance that it can come with.
Hmm.
But so when we release a guideline on this front,
Right.
we have to be completely aware of the fact that this is going to reach GPs
Right.
and
Right.
clinicians who may not be as much aware.
Right. Right.
So I think the risk of discontinuing it is probably lower than continuing it.
Yes. Okay.
So that
Fair
being
enough.
said, I think
Fair
we
enough.
have to
Fair enough.
go with whatever data is available and play it safe, and
So
so
I
that
this is
less harm than
Yeah,
benefit to
so
the
this is
patient.
exactly what we wrote.
Yeah.
So I think this line probably can go, right? Generally discouraged for inpatient use, except in specific heart failure scenarios, depending on the clinical judgment. So when you're talking about specific heart failure scenario, there will be a joint decision between the treating cardiologist and the other specialties, right? So I think that is where we could probably say. Uh, but but yeah, I mean this could be the thing. Metformin, uh, again, there are pros and cons of it, right? Doesn't produce hypoglycemia, but then there could be specific, again, there could patient could be potentially dehydrated, increasing the risk of lactic acidosis and so on. But having said that, there is absolutely no data to show any harm. In fact, the contrast part also, though it's written and some of the guidelines still stick to it, the current studies have actually shown that the continuing metformin produces no harm in contrast studies also. So, Sagar, metformin again a commonly used drug. What's your The guideline is clear that you should discontinue, but in a pragmatic, more practical purpose.
Yeah, so for that, we stop metformin in everyone who is admitted to the
Okay.
hospital. It doesn't matter if they're going to get a contrast study or anything else, everyone is stopped.
Stop.
Yes. So the only time the question comes up later is when do you restart metformin? And many hospitalists who take care of this are very uncomfortable with starting metformin when the patient is in the hospital. So they
Right.
always say, get discharged after 1 or 2 days if everything is good, start metformin. But some of the guidelines do say that if the patient is stable, you should probably continue metformin in the hospital or at least start it 2 to 3 days before discharge.
Okay.
But I think almost everyone stops metformin when the patient is admitted.
Okay. So again, can be put as a little bit of a query for the thing, but yeah, yes. Uh, yeah, correct. But 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 when we do that, sir, we would be actually will be the only guideline which says that, because all the international guidelines and especially the American ones. Yeah.
Is it going to harm the patient immediately? The first question. By stopping metformin, are we going to harm the patient immediately? Is the hyperglycemia is going to be precipitated immediately because of stopping? No.
Hmm.
Second, though contrast studies nowadays they are saying that it doesn't harm, but still, if you are aware that patient is on metformin, it is a practice to stop it at least for 48 hours. Inadvertently, even today, my one of my patient went for a CT urgently because some other new symptoms came up. We have to take him on CT, contrast CT. He was on metformin. So I consciously told he is a stable patient, no need, we can continue. So he went on CT. Now, if he lands up with a um, say
Contrast
acute kidney
nephropathy.
injury, contrast nephropathy. So we'll be in a soup. We'll be questioned why it was not stopped.
Right.
So better inpatient. Patient has something acute. So that's why the patient is in-house. So inpatient, admitted. Better at least for the duration of the hospitalization to avoid using metformin is a better option, I feel.
Yeah. So we'll go. I think we can go with this line, which, like Sir said, the existing line would be a good way of doing it because it is reasonable safety check, and we are not saying we are not encouraging use of metformin, but we are saying that in these cases better to avoid. Right? It says withhold if renal impairment, contrast studies, acute illness, or hemodynamic instability. Yeah. Of course, we are not. Yeah, so in hospital we are not initiating metformin anyways. We're not initiating. We'll be initiating at the time of discharge, right? But we are not. The question is more of withholding rather than okay. Thiazolidinones we can generally avoid, right? Anybody, nobody will disagree to that. But sulfonylurea is the one which will be area of debate. My personal recommendation is I generally stop it. Blanket. Reason is that I mean, hypoglycemia, if you're going to have with SUs. And the problem with hospital setting is that SUs, I mean, you never know when the patient goes nil by mouth, when starts vomiting, it's put on a fluoroquinolone, put on a glucocorticoid, many problems, right? And inadvertently, then you have hypoglycemia. Because again, you know, uh, uh, you'll be intensifying the glycemic management from your from your basal bolus also. So that patient who and sometimes what happens, and to be honest, patient might be having hypoglycemia which was never recognized until you started checking in the hospital, right? So blanket recommendation should be stop SUs, right? Now, Dr. Anchan, your question was, let's put this, because we can put this as a case scenario in our thing. Let's say patient has to undergo a daycare surgery, could be any daycare surgery, 1 day surgery, in and out, right? Maybe gets admitted in the morning, gets discharged the next day morning, right? 24-hour admission, uh, clean surgery, safe surgery, patient's doing well, HbA1c is well controlled. Uh, would you, and patient generally takes maybe evening dose or nighttime dose of SU or something of that sort. uh, would you then say that day before surgery, would you just continue SU or would you then stop it? For example, let's say patient has to undergo a scheduled, uh, you know, uh, joint replacement, right? Uh, or cholecystectomy, right? Patient's HbA1c is 6.9. He's on a small dose, 1 milligram of glimepiride, right? Patient is going to get admitted in the morning, get discharged the next day morning, right? Just maybe a few hours of nil by mouth. Uh, Clean surgery, laparoscopically done, no complications anticipated. Uh, the patient asks you in the evening, can I continue my metformin, my glimepiride dose today? Should I take it or should I not take it? What would be the call here? Yes.
Yeah. So the problem with sulfonylurea, they are mostly long acting. We don't know how many hours later it will cause hypoglycemia, and
Mm,
we are not even sure about the
mm,
patient's response to the surgery or anesthesia in the morning,
right.
whether he will start vomiting or he will,
Yeah. Yeah.
I don't like this or I don't want to eat
Mm,
this, mood niya, mausam niya, blah blah blah.
mm,
So we are not sure whether patient is his meal will be what type.
right.
So in my opinion, the sulfonylurea should not be started until 3 days, and we can supplement with small dose of insulin.
Right.
That's much safer
So,
option than giving. That's a logistic
but that
problem.
oh,
That's a logistic problem, not
that's
a
a practical
scientific
problem. So
problem.
he's right.
Yeah.
वो तो practical issue है ना. वो तो patient is supposed to come,
वो तो
but patient doesn't
relative ही
come.
लाएगा ना.
Hmm. That that वो problem है.
So you can choose one of the short acting sulfonylurea. So you can choose short acting sulfonylurea, like
But okay.
yeah,
What?
yeah, something like that. No, no, short acting. Yeah, maybe. Now I don't want to use the name of the trade name, but uh, so that can be used. Yeah, yeah.
But having said that, let's say ना चलो ये तो 1 milligram 2 milligram glimepiride है. There'll be patients on 4 milligram 6 milligram of glimepiride.
Oh,
If
there.
you stop that, it is 100% going to produce hyperglycemia. And
4
there
and
are,
6 are already in OHA failure, so you have
yeah,
to start
no,
insulin.
sir,
Otherwise,
you'll be
also
sir.
today or tomorrow.
अच्छा, मैंने कल I saw 12 milligram of glimepiride yesterday. So
I have
so
seen
so
16 and 24 also, but they
so
are दिग्गज लोग होते हैं. Though they are adamant patient कि we will not take insulin at any cost, so you keep increasing and nothing
I,
happens. They
I,
never go in hypo
yeah,
because
but
their
act
insulin
ही नहीं कर रहा है
resistance.
ना. SU is not working on this.
Exactly. So, so I always give them
No,
insulin
this
for
will
3
come
weeks.
to
Yeah.
discharge. Right now we are
Mm.
looking pre-operative, right? So yeah,
And
well, discharge
pre-op
will
we
discuss.
can always stop, and we can tell them also sugar is likely to increase little bit, and we can restart. Maybe at least 2 days before. Yeah.
Insulin.
Start insulin. And train one of the
So
family member to check blood sugar,
we can
insulin,
be
and all
we
these
can
things.
we can, no, we can categorically
Yeah,
say here,
government
because this
setup
is,
is different, but
yeah,
in private
this
practice,
is the most common scenario which everybody if you're not facing it, you're probably facing it and not knowing it, right? This is the most common clinical scenario, right? uh, so ideally, but this is what I would suggest, we should have a recommendation that a patient, especially on sulfonylureas, especially on higher dose of sulfonylureas, it should, the perioperative diabetes management should be planned. In a planned surgery, it should be planned. The patient should consult the treating doctor 2 or 3 days prior to the surgery. Just like, आप fitness तो लिखवाने आते हैं, right? This is the बाकी fitness तो is just regulatory. This is the place where your help is really needed, right? So no, sir. So what I do, no, what I do is, let's say the orthopedic surgeon calls me, right, or sends me the patient case. को हम 3-4 दिन के बाद, the patient is going to come next Monday for surgery, right? So what I do is, I, of course, look at the HbA1c and all that. You give a cover of, because I have a time, let's say 2-3 दिन का I have a leeway. On that day, you give a start with a low dose of basal insulin, ask them to strictly monitor and report back, right? And by the time that surgery happens on Monday, right, that SUs have been discontinued and basal insulin has already taken shape, right? So you have to have that time for transition also.
yeah.
So this is what I tell them,
And
especially patients on,
one more thing, the blood sugar doesn't rise immediately as soon as you stop. The half-life of sulfonylureas are different. So immediately, suppose you stop today, doesn't go tomorrow, it will be very high.
for
And you
example,
have a
but
window
yeah,
period.
but for example, patient,
So
no,
your
that is,
patient is eating then something else also, or his
no,
diet
no.
is
So
changing,
what?
something is happening. You
Yeah, so
look
you
into
plan
that
it out.
also.
So these are the things, issues with planned surgery, right? A planned surgery is where you also take glycemic planning into consideration. So I think that should be part of the guideline, that if it's a planned elective surgery, where glycemic control should be part of the planning protocol, right? And for example, let's say patient has regional wall motion abnormality, right? तो उसको थोड़ी तुम सर्जरी करोगे, right? Cardiologist will see, शायद एंजियोग्राफी भी करेगा, शायद एंजियोप्लास्टी भी करेगा, right? Before he sends the patient to surgery. Same way, the diabetes management, let's say patient is on 6 milligram of glimepiride, right? 3 milligram in the morning, 3 milligram in the afternoon. What I do is, ask them to stop the evening 3 milligram, put him on a basal insulin. Next day, I stop the morning one also, once the fasting sugar comes under control. And then by Monday, the ICU is completely out, and maybe the SGLT2 is also completely out. And the patient is now on a basal insulin with other OADs which are safe. And then the patient goes for surgery. So the point as far as the guideline is concerned should be that patients, especially patients on SGLT2, GLP, or sulfonylureas, uh, there should be adequate time for planning the glycemic management perioperatively. That could be a blanket statement where kitne din planning and other things would depend on the setup which you have, and the medications individualized based on the patient. But sir, that yeah, that's beyond the scope of the guideline. So- No, but then in that, not only that, you will require specific guidelines for orthopedic separately, GI surgeon separately, onco surgeon separately. So
But by and large, in all these operations, anesthetic plays a major role, and anesthetic is only manage. Yeah.
yeah.
So I usually say as per the anesthetist, and later on we'll take over here. पर यार
Yes.
consensus nuts Bandra के लिए हो रही है ना राजस्थान के लिए हो रही है. Consensus is happening for everyone, for the scientific world.
Okay. Your
The problem with all the surgeries, even if they're planned surgeries, 2 hour surgery, 3 hour surgery, laparoscopic, we don't know if it will convert to something worse. That is the problem. So that's why even for patients who are admitted, we stop sulfonylureas on everyone because we don't know what may happen tomorrow. We don't know what may happen in a few hours. So it's a more conservative approach, but that's what we typically do.
right.
Is it the best? I don't know, but at least it's a more conservative approach.
Exactly has to be done because every surgery looks very simple from surgeon's point of view, but once it is on the table, it's totally different.
Mm.
And post-op and the other care and are totally different. You are
Right.
telling nurse to give some insulin, she is giving something else. Relative is bringing something else, and she
Right.
forgot. You don't know what happens in the hospital.
So
I
yeah,
can't
I think
disclose all these things what happens there, but many things happens there. So we have to be very
sure.
careful.
I think same with GLP-1 RA. So GLP-1 RA, the risk is gastroparesis, and there are clear recommendation that we are limited inpatient data, should not be used in inpatients, and should be discontinued, especially from gastroparesis perspective, right? So risk of, and I think again anesthetists are also very clear about it. And I think this is a point we can add is that for the newer generation of GLP-1 RA, the anesthetists need to be aware about the mechanism, because remember these are weekly injections, right? So patient would be on a GLP-1, so they again that has to be taken into planning and consideration while giving therapy. I think we are already way beyond time. We have one more point. We'll just discuss the discharge part, and then we'll go to Dr. Ketan to talk about. Yes, yes, sir. Yeah, we'll discuss the discharge part. Yes, yes.
and in a different way. So, after giving a final discussion, that final decision that what has to be given at the discharge note, whether that patient is following
We're
your
just
advice or not,
discussing discharge,
yeah,
sir. We are
that
discussing
is,
discharge.
yeah.
So in discharge, so these are the recommendations which we said, which are in line with the international recommendation. Discharge planning should begin well before actual discharge, which I'm sure everybody will agree. Factors should be, like you said, all these factors have to be taken into consideration. So affordability, educational status, competence, compliance, psychological factors, etc. Now, as a broad guideline, if HbA1c is less than 8, generally you can continue pre-admission medications unless there are contraindications. If it's more than 8, you will have to probably intensify the therapy, and that intensification would depend on the clinical judgment, right? Uh, and newly diagnosed patients with high HbA1c, you can of course give standard treatment. Some patients will have stress hyperglycemia. That is where again HbA1c is really important. So in that case, you can just monitor the patient and discharge the patient without anti-diabetic drugs, but monitor. Uh, Again, you need to look at the discharge educational components, how to take insulin, other things also. This is very important. So if the patient is going to be discharged on insulin, the patient needs to be explained how to take insulin, because also very importantly, and I'm sure this is to be uh, what happens, and this is frequently happening to what we realize, patient during hospital stay is on a I'm just taking the brand name for example, is on a Lantus and a Fiasp, right? And gets just discharged on a Lantus where we discontinued Fiasp, right? So the patient continues to take Lantus, but then he runs out of Lantus, he continues taking Fiasp, considering that it's the same insulin, right? So often we discuss this, the changes of insulin, other things. So I think these has to be very categorical. And that's why, my assistant, when she goes, she always makes sure that the patient is told that this is not substitute for the other insulin. So if you run out of your Lantus, you need to buy more Lantus, right? You will not be using Fiasp in place of Lantus, because for them, every insulin is insulin, right? So yeah, so that is it. But again, depending on the situation where how you are going to anticipate, right? So if the patient is on a very high dose of SU and you're anticipating patient will develop hypoglycemia, then it's a clinical judgment you take to not give that, right? That's my plan, right? So, Yes. Yes.
It is not the problem of discharge or anything else, because it happens with OPD as well.
Yeah. Yeah. Yeah.
They have older medicine, they continue.
Yeah, yeah.
It is required.
No, no. But we can. What we can say is that we. But Dr. Rutul, the point is that couple of things. It's since the patient is hospitalized, we have an opportunity to use that opportunity to educate and inform them, because uh, OPD you have 7 minutes, 10 minutes for the patient, right? Here, when you're going to see the patient, or at least the system, patient is for example, a patient on a a cashless thing, it'll take 4 hours for them to get discharged, right? So, 4 ghante mein you can use that time.
Still means
No, you don't have time. But I mean nursing staff, right? So the nursing staff, administrator, whatever, right? They can use that opportunity. Dietitian, you train a dietitian, tell them that at least insulin kaun sa hai wo samjhao. Teach them how to use insulin. There's a good opportunity, and it's a good opportunity to teach them how to then becomes easier for you in outpatient, right? So
finally, inpatient should be admitted. We start teaching them.
yeah. It's an opportunity to teach them about insulin.
What's the injection?
Yes. Very true. Completely agree. Uh, Again, more of a practical point. So these are the thing. We'll now go to the. I think in hospital hypoglycemia management is also part of the guideline, which is more or less standard. I'm sure we'll all agree to hypoglycemia. I'm sure there should be no disagreement. The final point will be special circumstances, where we have a few slides from Dr. Ketan, where we'll be, we'll quickly go through that, and then we'll call it the day, and then we'll take it up later with the points of where we need to discussion. Right? Please.